Assalamu alaikum. Good day, everyone. Welcome to our webinar. I am Ala Al-Umari, a patient safety specialist, and I will be serving you today as your moderator. Kindly notice that you can post your question in the Q&A panel, and your question will be answered by our speaker gladly at the end of the session. You will be hearing today from Dr. Abdulaziz Al-Qahtani. He will be speaking to us on discrepancy and miscommunication during transition of care. Dr. Abdulaziz Al-Qahtani is a consultant ambulatory care clinical pharmacist and the chairman of Pharmacy Staff Development Unit at King Saud University Medical City. Dr. Al-Qahtani is the chairman of the Ambulatory Care Clinical Pharmacy Specialist Network within the Saudi Society of Clinical Pharmacy. He is American board certified in ambulatory care and medication therapy management. Dr. Al-Qahtani received his Doctor of Pharmacy degree from King Saud bin Abdulaziz University from Health Science. After graduation, he joined the residency program GBY1 at King Saud University Medical City in 2019. He was granted the Saudi Board degree in General Clinical Pharmacy, ASHB accredited, and then he pursued the specialized Saudi Pharmacy Residency Program in Ambulatory Care. Dr. Al-Qahtani has presented several talks at national and international events. His current research focuses on clinical services management, clinical outcomes, comparative effectiveness research, and health education. Now moving along to our session, please welcome Dr. Abdulaziz Al-Qahtani to deliver the presentation on this very timely subject. Dr. Abdulaziz, if you might, please.
Assalamu alaikum. Good evening, everyone. Thank you, Ala, for your introduction, and thank you for everyone who attended this lecture. Today, inshallah, we will talk about the transition of care services and how its value and how its outcome to prevent discrepancy and optimize patient safety. As you know, patient safety is our ultimate goal in all healthcare setting, in terms of management, in terms of prevention the disease, and even though those patients is our relative and maybe those who everyone who enter this health institution, so that when we talk about the medication, it is the cornerstone of any curing of the disease. For that, we will go through this lecture how we can know how we can optimize the services or in terms of transition of care in all settings, either acute setting or in ambulatory care setting. Through this presentation, we'll go through the definition and the goal and the background of the transition of care, and we will go through some topic related to this matter. In addition to that, we will conclude our presentation with a project we did it in our institution to share knowledge, and if you have any further comment on that, we can discuss it by end. When we talk about the transition of care, generally, we talk about referral from that refers to the formal process of reviewing patient. It is a complete medication regimen before and after any transition or in care, transition in care. At the time of admission of hospital, after changing in the clinical unit or prescribing doctor, or following discharge. This is the definition of transition of care or medication reconciliation. Medication reconciliation, it's one of the cornerstone in the transition of care. When we conduct when the patient move from level of services, we can see it from here, from this slide, in acute setting or preventative care. When talk about sitting in acute setting, the patient will come to the ER. This is considered the entrance gate in the hospital. Patient come with acute illnesses, so that the healthcare provider will be their focus mainly on the acute symptom. So that upon that time, it's our role as a healthcare provider in all aspects. We talk about physician, nursing, pharmacists, whatever of those specialized in healthcare provider, we do reconciliation. This kind of reconciliation, it's also mandatory when the patient change from sitting to another sitting. We talk about ER to the ward, and also from transition within hospital, and like a patient shifted to intensify unit, like when we talk about the ICU sitting, or he get out from an ICU sitting. In between, in each sitting, we need to do also reconciliation to assure the medication he was on, it's still ongoing with another level, or optimized in better way. And when the patient, even though discharged from hospital, when we talk about acute setting, he get into the hospital and he received all the needed treatment. And upon that, he discharged from hospital. We need, before the discharging the patient, to do a reconciliation to make sure his medication, what he is, what's added on during his admission, it is optimized what he was before admission. When talk about primary care patient, once he discharged from hospital, even though he will go to the primary care, so that we verify all the added medication from the previous admission in hospital. And once there is needed consultation, we refer the patient to the specialist. This is the cycle in acute care. When talk about preventative care, that some individual who doesn't have any acute illnesses, just he going to the primary care center to take their medication or refill their medication, or asking for about any education. This is considered also another setting. We need to do reconciliation, and this is considered as a transition of care. When talk about primary care, a patient, he come in and we take all the history of the medication, and we'll talk about the step how we can do reconciliation with the transition of care. And also when talk about pharmacy, also when talk about specialist care, home health care, laboratory, and acute setting if the patient needed or referred to this setting. I hope it's very clear when we talk about the transition of care. You know, the aim of medication reconciliation during the transition of care to obtain and maintain the accurate and complete medication information for patients, and using the information within and across the continuous of care. And from that also we aim to foster patient safety by identification medication error. As you know, once there is issue in their medication regimen, it is a considered error. When talk about the error in general, we have multiple type of error. We talk about error of omission. We can say we have error of commission, and we have discrepancy. Each of those kind of medication-related problem, it is identified and well recognized, and from our strategy to prevent the medication error, we can optimize the medication therapy and prevent any consequences to our patients or to our community, health community, individual who taking service from it. We talk about the medication error in terms of omission, where the drug was completely not given. Once the patient come to the ER for any reason and admitted, once he discharged from hospital, there is a missing medication from the previous, missing medication is not prescribed by either because there is no documentation upon admission from ER, or there is a missing in entering medication. When talk about error of commission, where the drug given incorrectly, for example, we talk about someone who take, like, for example, insulin, glargine or glargine, and upon discharge, it's prescribed for them or for him aspart instead of glargine. So that this is considered as a error of commission. When talk about a discrepancy, it's mean reporting difference between the medication taken by the patient prior to the hospital admission and the medication order in the hospital. We face this, or we come across this error once the patient is taken from an institution and he admitted to another institution. In terms of this changing from service or to another service, it might be happen medication is not formally managed, formally listed, or medication having a different brand, or name it, from things related to the discrepancy. And it happened a lot. And this is the most common medication error happen during the transition of services. When we classify of a discrepancy, it's important to differentiate between type of discrepancy. Sometimes there is no discrepancy between before and after admission, and there is intended discrepancy, because that means not every discrepancy it's considered error, or it's unfavorable. When talk about intended discrepancy, either there is a new justified or a new drug justified by the situation. A patient come to the ER with something happened to her, to him, in terms of medical condition, worsening medical condition, or he needs escalation of therapy. So that this is considered as a discrepancy, but it is intended by the situation, or by primary physician who care about, who take care of this patient during the admission. We talk about medical condition or medical decision not to prescribe or a certain drug, or change its dose or frequency or route of administration based on the clinical situation. And sometimes it happens replacement of a drug with one of included in the hospital formulary. This kind of intended discrepancy, it's not considered as an error, as long we identify this kind of discrepancy and we document it. What we are fearing, we need to care about those kind of discrepancy, that an unintended discrepancy. Either the drug is omitted, or treatment started with no clinical explanation, different dose or frequency or route of administration, different drug or therapeutic duplication, which is happen a lot. A drug not available in the hospital without therapeutic interchange. For example, as I mentioned, sometimes it happen shortage of medication in certain hospital. The patient come to the ER with a list of medication. When they are entering, the medication is not available upon that hospital setting or institution of setting. Moving with that, more focusing on the acute setting and forget about the other chronic disease, while patients should be taking the medication to control and optimize the health in general. Once we understand those kind of medication error, when talk about commission and omission and discrepancy, it gives us now, before we talk about the importance in transition of care, a picture how it's value in to care and to implement such those program and reinforced by quality and safety projects. When talk why do we need for medication reconciliation, we know our ultimate goal for medication reconciliation, it is preventive error. When talk about the error, we have numbers of study published all over the world talk about how it's dangerous to leave a patient without monitoring on their medication, how it affects their medication or medical condition, and also how it costs the institution in terms of expenditures or readmission costs, and name it, from the drawback of not optimizing the medication and preventing an error that might have worsening the situation or make the treatment plan is not reached to the successful end, or it's what kind of worsening scenario it might happen to the patient. One of the occurrence of unintended medication discrepancy at the time of hospital admission range up to 30 to 70%. So that when talk about the discrepancy, it is important to care about it, and it's measurable KPI in each hospital to identify this gap between before and after admission in terms of medication for each patient. What about in our region? It is we are not different from the world data. We have a lot research published. I cited one of most of yeah, that mean one of the most study that talk about in this topic. Medication rate error rate over 1 year study period was up to 0.4%. We can say almost 1,000 over 250,000 prescription. Our ultimate goal usually for in terms of medication error is 0. So that when talk about 0.4, it is meaningful and significant increase from the reference number that intended in each hospital or health institution setting. Moving to the part of classification of discrepancy, as we mentioned before, discrepancy, it's important to know about this matter of unintended and intended discrepancy. Why we should do a medication reconciliation to give the patient the accurate home medication while under your care, ensure accurate transfer of medication information from one care setting to another setting, and also to confirm that new medication do not duplicate or interfere with current medication. In addition to that, also we want to ensure that patients know which medication they should be take, and prevent adverse drug reaction and medication error, and comply with regulatory standard. When we take each of those elements that I mentioned, why we have to, or what's the ultimate goal from medication reconciliation, we can see it and we can touch all the factors that we need pinpoint in medication reconciliation. Moving to the core of this presentation, how we can do medication reconciliation in terms of transition of care. We have multiple ways, and I can present for you here the most common and reliable process that once applied in the level of services or level of care services, it would be very effective and also valuable. Upon the start, you have to verify and then move to the clarify and reconcile. What we need to verify, collect the information regarding the patient is currently take, when last taking prior to admission, and also to assess the adherence of the adherence of the patient to the medication. Once you take all and collect those information, clarify and clear information collected during the verification process. This is the first two part. It's the most important and cornerstone of reconciliation. Once you collect the information in accurate way or in proper way, so that you gather all information. And I will mention in a following slide what's the information we need to take it from the patient or collecting from the patient. And specifically, we have to not using the end open question. We need to start with open-end question, so that are you taking the medication? Do you feel you are good with the medication? All these questions, it might be end up with one answer like yes, no, yes, no. At that time, you will not receive or you will not get full picture about status of adherence and also other medication. The most favorable style of collecting information, open-ended question. We can say for this patient, what is your medication? How you take those medication? When last time you took all this medication? You give the space for the patient to speak or the caregiver to give you more information that might be it's valuable. They don't know it is important for his status, but for us as a healthcare provider, it would be change. It might be change the treatment plan. The last part or last step of medication reconciliation is reconciliation itself, comparing the classified or compare the clarified list against the admission or discharge medication order and reconcile any discrepancy. So that once the patient come to the end upon the admission, we need to collect and verify those information and document in the system and reconcile upon changing any care of services or upon the discharge. When talk about in terms of collection and in terms of in the process or in the step of collection and verification, we need to develop a list of current medication. We need to develop a list of medication to be prescribed and compare the medication on the two lists and making like clinical decision based on the comparison. Finally, communicate the new list to the appropriate caregiver and to the patient it's their self. Here, this kind of 5-step, once you apply it, you will have ultimate goal from preventing patient discrepancy or usually medication discrepancy, and you will optimize the care from the institution, and we will end up with a better health outcome for the patient, and also you will reduce any cost from prescribing medication that is not improper or prevent the medication related problem in terms of before and after or in terms of transition of care, in terms of patient coming to the surface or moving from care to another level of care from either inpatient to the outpatient setting. What type of medication we need to reconcile and documented while we are doing the verification and collection process, all the prescribed medication before and after admission, also herbals, vitamins, natural supplement, OTC medication, vaccine, diagnostic and contrast agent, radioactive medication, parenteral nutrition, blood derivatives, intravenous solutions. All these, it's considered as a medication or pharmaceutical type of pharmaceutical item. We need to reconcile it and document it in the patient file or in the list belong to this patient. Once we bring this list, we will compare it before and after admission or before and after any level of services that can be provided for any patient in terms of health management. Who should be involved in the medication reconciliation? What do you think, in your opinion? Who's the most important person in the level of services or level of in health institution to take care of the medication reconciliation? I think from your mind, or I can guess from your mind, as long as it's medication, should be the pharmacist or the nurse. What do you think? I can guess and I can inform you, everyone in the level of healthcare setting should be involved in medication reconciliation. When talk about a prescriber or a physician, when talk about a nursing, pharmacist or patient and patient patient or family caregiver, all those participate in medication reconciliation, so that the responsibility is not belong to or undergo to the one of the healthcare provider. It is a multidisciplinary team should be involved in medication reconciliation. The prescriber has a role, also the nurse has a role, pharmacist has a role, and the patient itself or family caregiver, they have the biggest role in this medication reconciliation, because we're taking the information from those individual to verify, to compare it with the actual or whatever of medical record medication list. Here we can say about the GCI recommendation in terms of medication reconciliation, the place of medication list in highly visible location in the patient chart, create a process for reconciliation at the interface of care and admission setting, also in transfer setting, and also in discharge setting. Provide the patient with complete list of medication that he or she will be taking after discharge from the facility, with instruction on how long to continue taking any newly prescribed medication. Encourage the patient to carry the list with them and to share the list to the next provider care. And this is the most important, and the strategies should be applied in all health institutions to prevent any discrepancy or to optimize the patient care. When talk about each one of those recommendation, we can easily apply it in our daily activity. Finally, we will talk about how the pharmacist can be helped in this setting. As long we know the pharmacist, one of the he's the drug information resource in all health setting. So that I will mention about its responsibility within an institution, and it's nice when talk about the healthcare provider to empower the pharmacist in your service to lead or take leadership in this process, as long he knows about all the type of medication and also drug interaction about the medication. And in addition to that, that might be interfere with the patient when talk about the traditional herbals that the society or community is taking. He's very understanding the situation of the medication in term of patient culture or patient community around the institution. One of the responsibility of pharmacists that recommended by ACHP, providing a leadership in designing and managing a patient-centered medication reconciliation system, educate the patient and healthcare professional about benefit and limitation of medication reconciliation process, and serving as a patient advocate throughout the transition of care. Also, one of the recommendation from the SHP statement on the pharmacist role in medication reconciliation, they have role in policy and procedure development. Also, they have a role in implementation and performance improvement, training and competency assurance, and advocacy. All these domains of responsibility can be led by pharmacists in your institution, and significantly will have a better patient outcome once it's applied in ideal situation and documented in the quality project outcome. Here we can say about what things can be done through the policy and procedure development, provision of patient care services that include the medication reconciliation process, implementation and operation of evidence-based medication reconciliation system that optimize the available resources, and also its education of organization staff on the importance of medication reconciliation as a patient safety initiative. In addition to the second module of implementation and performance improvement, they can do establishment of a medication reconciliation implementation task force and redesign the team, creating a vision and expectation for medication reconciliation activity, identify the barriers that preventing or potentially barriers that may prevent and safe effective medication reconciliation. In addition to that, they can develop a method for ongoing medication reconciliation system evaluation. In terms of policy and procedure development modules, in terms of training, and competency assurance, identify all healthcare providers involved in medication reconciliation activity and provide education and performing assessment to ensure the competency of those who document and perform medication reconciliation activity. Last module of in terms of medication reconciliation that pharmacists can have a role, advocacy. He can demonstrate the effectiveness of sound medication reconciliation process in improving patient safety and reducing the healthcare costs. All these modules can pharmacists in your institution participate and effectively will have a value or significant outcome once they take leadership, not because the other is not can do it, but the ownership of medication related to the pharmacy, so that we usually leave this kind of services to the pharmacists and empower the other healthcare providers to do their more specialized services when talk about prescriber and also nursing. Lastly, we'll talk about I will talk about one of our projects in our institution, King Saud Medical City. We do a project to measure the patient outcome once the pharmacists or pharmacy services interfere in transition care. As long we are ambulatory care clinical pharmacist specialists, so that more intent to the patient once he discharged. And we measure the value that we get it once we reconcile and we reconcile patient upon discharge. Our method in this project, it was a cohort study conducted in the hospital, and we divided the patient into module or two arms. One arm come to our transition of care services. The other arm will be go to the standard of treatment or standard procedure that everyone in our hospital goes or everyone in the hospital discharged from hospital every patient who admitted to our hospital and order for him discharge the procedure. This is our including our total population included in our project is almost 167 patients, divided into 3 groups: full intervention group and half intervention group. And we talk about the control group. It is the standard of care management or treatment or reconciliation, that we let the patient to go through the procedure that done in daily basis or regular situation. In terms of full intervention group, before discharge, we come as a team, clinical pharmacist, to counsel the patient about his medication or her medication. And we do a phone call at 7 to 14 days just to verify any issue happened to the patient or any inquiry about their medication in terms of medication therapy management. And also the third part of this project, we do another follow-up session after 30 to 60 days to assess the patient in health status and also about the medication regimen. And also we talk about in general to answer any inquiry. In the half intervention group, we do counseling or reconciliation or transition of care upon discharge, but we didn't call the patient upon after 1 to 2 weeks. We assess the patient after 1 month to 2 month time. The third group, in control group, just anyone discharged from hospital, we call him after 30 to 60 days to assess the difference between when we do a counseling and full session about how he's taking medication and follow up after 2 weeks and 3 months and upon from the discharge time. all this information related to the project. Inclusion criteria was for all adult patients, excluded anyone admitted for less than 24 hours, left against medical advice, or that means he's not complete his medical treatment, or discharged to another institution setting. That means the patient is not discharged to the home, it's discharged to another hospital setting or care setting. The primary outcome from the study to assess the effective of TOC service on readmission and ER visit rate between the three groups at 30 days and 60 days follow-up. The secondary outcome from this study to assess the patient adherence and also to assess the patient satisfaction. Here, some demographic data about the individual who recruited in this study. As you can see here, the total, as we mentioned before, it's almost 150. The average age they consider is most likely elderly patient who to this kind of this is targeted population in our project, which have more than they have a lot of medication taking in terms of chronic disease or in terms of comorbidities. Those individuals have it. And the last part, we assess also length of stay before they during the admission. In full intervention group, almost the average is 8 days, and in half intervention around 11 days, and in control group average between 6 days. The primary outcome from this study, imagine how it's significant when we see it or compare it from full intervention and control group. We can see the readmission rate from the discharge time up to 30 days, and in full intervention group, almost 8 readmission. We talk about in control group, 13 admission. And also upon 60 days, that means 2 months from discharge, we can see here from the full intervention group, almost readmitted 4 patients or 44%. When talk about the control group who doesn't take the reconciliation or transition of care and full services of education about their medication and follow up after 7 to 14 days, and also another follow up after 2 months, increase the level or rate up to 93% of those patients is readmitted. Here we can see the significance between all control and full intervention group, and statistically significant. There is a difference, and from these numbers and from this number show how it's important and valuable of transition of care services in all hospital setting. We talk about the medication adherence. We assess that after 14 days and 60 days, and we found also significant results in terms of adherence about their medication. As long as the patient he understands why he is taking medication, and someone is encourage him to take it in proper way and prevent any adverse event or drug interaction or inconvenience from those medication, definitely the patient will follow and taking their medication. Lastly, we assess the medication-related problem, and we found there is this, also in terms of full intervention group compared to the control group, there is much difference between the two arms. We can see numbers between both of group significant when talk about someone who caring about the patient and follow up with the patient is much less percentage in term of medication related problem compared to the control group. Here we end up with our session, about take-home message documenting a complete medication history and plan. It is important and it's meaningful. Definitely will have a clear listing about the patient medication that's helpful upon transition from sitting to another sitting until he gets back to his home with a proper and effective and optimized medication regimen. Reconciling at admission, ward, hospital, and transfer and discharge reduce the medication error and patient harm, providing accurate information at all level of transition of care result in safe ongoing care, which is this is our ultimate goal in patient care in all hospital and healthcare setting. Finally, I end up my talk with safe patient care is our goal always in all hospital setting or in our patient care. Thank you for your attention, and more than happy to hear any question related to this topic.
Thank you, Dr. Abdulaziz, for addressing this interesting topics. And now, my dear participants, we will answer the question that we receive in the Q&A panel, and you still have the time to post in any question. Dr. Abdulaziz, our first question is, how can we apply patient and family engagement concepts in this matter, in the transition of care and patient reconciliation?
Sorry, about, can you repeat your question, sorry?
How can we apply patient and family engagement concept?
Yes. In terms of applying this, once we increase the awareness about the importance to sharing the information from the caregiver or the patient while he admitted or come to any level of sitting, would be very helpful for the transition of care services, so that the first cornerstone or the first step in applying a transition of care in terms of patient or caregiver to aware the patient once he come to the services or in healthcare services, to educate him how it's important to spill out or to share with any healthcare provider the information related to the medication.
Thank you, Dr. Abdulaziz. Our second question, as you know, a transition of care is can be through different departments at the hospital or for transferring from other hospitals, and especially the transferring from ICUs. Maybe the major barriers is the staff shortage and limitation of time. So, what's your advice to overcome these barriers?
Well, I'm from my side, I'm not seeing the shortage of staff or the time is reason for affecting the patient safety. So that once we have a quality department, they will assess and they will make sure each patient has to have a clear list from each sitting, so that the prescriber or the nurse or the pharmacist, if there's a clinical pharmacist in the floor in ICU setting, he has to, in daily basis, a list of updating medication, either the patient who received from other ward to the intensified level of service, or the patient who get cured and get relieved from him symptom or acute setting and transferred to the ward. From myself, the barrier, it is a documentation. Once we have a proper documentation during the sitting, would be solving this barrier.
Thank you, Doctor. Our last question, in the absence of a unified medical files, how can we improve a transition of care during hospital transfers?
To be honest, this is one of our challenge. We cannot dismiss this part of challenge. Once the patient is following with other hospital or other healthcare institutions and come to a new institution or healthcare institution asking for help or asking for medical services, unfortunately, we cannot get access to the previous one. We can avoid this by proper awareness for the patient, how he can clarify and bring his clarify his medication. This one, if the patient is not in the level of either he cannot remember about his medication, name of the medication, or shape of the medication, or his condition, we go to the second level of the caregiver, either his mom, his father, or brother, or sister, or whoever who taking care of this patient, to ask him about this question about his medication in terms of RX medication, prescribed medication, or OTC medication, or any herbal or other product he is taking. If the both of them is not providing a helpful information or clear information, we can also ask the patient to bring all his medication. And this is our daily basis activity in our ambulatory care services. The pharmacist or clinical pharmacist in outpatient setting or in outpatient setting is arrange an appointment for each patient to bring their medication, everything related to the patient. Once the patient come to our clinic, we analyze all, we collect all the information, and then we analyze all the medication he's taking, from medication prescribed, from the medication is over the counter, also the things he's might be taking from his friend, from whatever herbal products that might be he think is improve his health or get relieved some symptom, and we link it together and clarify anything related to those medication and document in the medical record. Those items or those strategy or those way, we can effectively get all his medication if we don't have access to other healthcare institution he's usually or he used to taking care from them.
Thank you, Dr. Abdulaziz. We reach our end of the presentation. On behalf of the Saudi Patient Safety Center, we would like to thank Dr. Abdulaziz Al-Qahtani and the audience for their active participation. As a part of the Saudi Patient Safety Center effort to provide you with timely topic and interesting speakers, we would appreciate if you would fill out the evaluation survey sent to your email after the session. Thank you for joining us today, and we look forward to welcome you back in a future.